let's start, as I said, with these couple of questions. So take a minute to think about them. You can jot down your responses, take like a minute or two, and then we'll share out. And as I said, I like to start this, every talk with this slide, because digital interventions, the digital intervention that we're creating for what I'm going to talk about today is a game. And these questions will help remind us why we enjoy games and how they teach us skills.
I'm putting in mine right now.
Okay.
So
perfect.
Yeah,
I'll give it like another 30 seconds. And I'll start with my responses too, just to like get the ball rolling as well.
all right, do you want me to shout out some of them, because we do have some coming in at this point?
Yeah, I think like, here, after I do mine, you can then just start shouting out people's names.
Okay.
Okay. So my response, my favorite game as a child was Tetris. My favorite game today would be Jenga, and then like Dr. Mario as a close second. And the reason I like these games is because I'm a process person. So I enjoy thinking about how things connect and how they fit together, as well as what structures are needed to remain strong. So who wants to go next? People can just shout out, or, Lauretta, feel free to call on someone.
Well, yeah, Yuka went next. Yuka, do you want to talk or?
Yeah, I forgot about Tetris. I played Tetris for hours.
Right?
Yes, it was so good.
So good.
I put Mario Kart because I also had like the original Nintendo set straight from Japan. And now, you know what's sad? I really had to think, because I don't play games anymore, which kind of made me sad. But the last one I played was Cranium, and I just remember really laughing a lot when,
Right.
people can do really goofy responses. So it was fun.
Yeah, so laughter.
Mhm.
Yeah, for sure. Anyone else?
I'm just going to go because actually it's very consistent with what Yuka said. I said I couldn't think of, I'm not a game player, so I couldn't think about things that I had played, Chutes and Ladders, to tell you how far back I went. But now that you and Yuka went, I really love solitaire, but I also like Sudoku, because I like the logic,
right.
and the process. So that's me.
Oh, I love it. Yeah, thank you. You reminded me of Sudoku. Yeah, that's a great game too.
Francesca, do you want to go? And
sure. So I said Monopoly as a child, but now that I'm thinking about it, I loved Wii Sports or Rock Band with my family. Like, I would always do the guitar. And then now I said like any easy card games with friends. I feel like that's a nice social time, but they have to be easy for me because I'm not too good at them.
Why don't people just shout out?
Just jump in. Yeah, jump in.
Sure, I'll say, like Francesca, I'm also not good at card games, but everyone else in my family is. So the game I like to play with them is Santan, because it's like, it requires some skill, but not that much. So I can hang in there when I play with them. But when I was a kid, my favorite game to play was Clue. We were like, my sister, my cousins, our neighbors, we were obsessed with it. We'd play the game, we'd watch the movie. It just felt like, yeah, we were just completely obsessed with it. And I still love it.
Awesome.
And I said Uno as a child. I just really love the colors, and I love card games, and I don't really have a favorite game right now. I guess life is way too serious. I need to figure out what kind of games I like.
Bring games into your life. Yes. And is there anyone else? I can't see you, so I just want to make sure I'm not missing out on anything.
So Shoshana, why don't you tell us what you like as games?
I put in the chat Hungry Hippo, which is like a game from like 80s, like early 80s. That was fun. But as people were talking, I really liked Connect 4.
Okay.
Yeah.
Awesome. Great. Okay, well,
What-
thank you. Oh, sorry, is there anyone else?
No, actually, there isn't anybody else, but I think, listening to others really kind of, help several of us say, well, we're really not
Generate
game
ideas,
players, but then come up with something.
Absolutely.
So,
Yeah. And that's when you also realize too, like, well, you can also develop skills or just enjoy video games. They can be video games for good as well. So we're going to talk about those type of video games today. So thank you so much for joining me today. I'm excited to share more about the development of a digital game intervention to prevent suicide among youth who misuse opioids. Today's talk will cover our learning objectives, a brief introduction to our lab, the HEAL Initiative, and Play Smart, just to give context to how the current project evolved, a description of the current project called Support Ed, Q&A and discussion. And if you have any questions, I see this as a really super informal, the way this group operates and the way I love it to operate is just an informal discussion group as it's named. So just speak up, interrupt, no need to raise your hand. I can't see you. And as I said, I want this to just be a discussion. So please, like I said, jump in.
if I see somebody raise their hand, I'll interrupt.
Awesome. Love it. Thanks, Lauretta. So our learning objectives for today are the following. Attendees will be able to describe the development process of the digital game intervention to address suicide in youth who misuse opioids. In addition, attendees will be able to identify specific approaches to enhance the rigor of this study. And then lastly, I'd really love for attendees to suggest other approaches to improve the data analysis plan that I'll get into later. But before I dive into our work, I always like to tell people a little bit more about me. My name is Claudia-Santi Fernandes, and I'm an expert in adolescent development as well as school-based research and programming. I started my career actually as a public school teacher, later became a bilingual school counselor, and then I was part of the leadership team in opening up a Bard High School Early College in Newark, New Jersey, where I oversaw student support services. In 2013, I decided to transition to research, where my dissertation was extracted from an NIH grant on school wellness policies out of the Yale School of Public Health under Jeanette Ikovics. And that is where and how I learned, I met Yuka, who is on this call right now, and she was my dissertation coach and helped me finish that, cross the finish line. And I'm always so grateful to her support and her knowledge about the qualitative research process. But during that time, I really fell in love with research. And in all of these experiences, I saw how research was able to impact a greater number of youth, as well as engage a greater number of youth. And this led me to today, where I am the Deputy Director of Mental Health and Wellbeing at the Play to Prevent Lab. And I'm also an assistant professor at the School of Medicine. I also am a licensed professional counselor in private practice. So I always try to keep one foot in practice as well to enhance my understanding and improve my understanding of the research process. Central to my work, then, now, today, is really promoting youth voice. So we at the Play to Prevent Lab at the Yale Center for Health and Learning Games, we design, develop, and evaluate video game interventions to promote healthy behaviors in youth and young adults. We are an academic research lab, and we target prevention. So we do this work using what we call our collective brain, consisting of a small core team of experts in research and intervention design, health behavior change, adolescent development, school-based interventions, community engagement, and gaming. And Fran, who is a PGA at our lab here today, Fran, you could wave, again, I can't see you, but she is my right hand in this process, and she has been so instrumental as we get the current project Support Ed up and running and launched. So very quickly, I just want to share, and let's make sure that I can do this. I'm going to share a little blip. Let's see how this works. If you can't hear, please just speak up and let me know. Second. About our lab.
Grammarly does more than catch errors.
We're good.
Okay, good.
No,
Uh-oh.
or explicit.
At Play to Prevent, our video games are built by teens and young adults.
For teens and young adults to help them live happier and healthier lives. Their voices, their stories, their visions, that's where the games are built from. It is really a collective brain, not work that can be done by any one person or any one of us. It is students, teachers, game developers, scientists. For the development of our video game interventions, everybody brings their expertise.
Community partners can range anywhere from after-school programs to schools. We always start off with focus groups with our students. From that information, we're actually able to glean what information should go into the game, storylines that would be relevant to the kids. It helps us develop different characters that might be in the game.
The greatest part about what we do is having kids design and being involved from the bottom up. They really kind of form a lot of the stories and the narrative.
We'll take the game to our game developers, we'll build out a prototype, we'll take it back to our students and say, is this relatable? Does this work?
So we're passing out headphones so you guys can be totally immersed in the game. During the gameplay sessions, we observe their reactions to the game. They're having trouble on different levels.
When they play test, they provide feedback on what worked, what didn't work. Teens love being honest and love sharing their opinions.
I like the strategy and the competition.
In this game, you really don't have that much of a penalty, but in real life, you could lose a job, you could lose friends.
The only way that an intervention is going to have impact and meaning is if it is from their voice. A critical part of this work is being able to measure the impact. We conduct randomized controlled trials, the gold standard, and we've been able to demonstrate that our games have statistically significant impact on different outcomes that we're looking to measure. So in the short term, we're continuing to build our evidence. In the long term, the key is to really get these games out broadly.
All right. So I like to always show that video because I feel like it gives a really comprehensive understanding of the work we do. So to do this work, it is an iterative process, and we always start with youth. Every step incorporates youth voice, and our games are built by youth for youth, as the video shared. So for example, our process is this. During the design phase, we conduct focus groups and interviews to inform the content of the intervention. During the development phase, youth play test and provide feedback. And then during the evaluation phase, we conduct a pilot study if it's a prototype, or a large-scale randomized controlled trial if it's a fully developed game. To understand how I found my way to the current project, I want to start at the beginning. And the beginning is the Helping to End Addiction Long-Term Initiative, the NIH Heal Initiative. So given the national opioid public health crisis, almost every single NIH institute or center invested in accelerating research to address this public health emergency from all angles. And this initiative requires ongoing input and engagement, in fact, from experts across all disciplines and sectors. So specifically, the National Institute on Drug Abuse, NIDA's primary call for the Heal Prevention Cooperative was to address the opioid crisis among at-risk groups of youth and young adults between the ages of 16 and 30. Our Heal Prevention Cooperative consists of one coordinating center, which is RTI International, and then 10 research projects from different universities across the nation who are funded to test and implement evidence-based interventions designed to prevent the onset as well as the escalation of opioid misuse among at-risk groups of youth and young adults. So this has been an incredibly collaborative initiative, and certainly I would add this as a highlight to my career, being part of this initiative. with oversight from the steering committee, which consists of the principal investigators from each HEAL research project. So now I'm going to walk you through our team-specific research project where Dr. Lynn Feline, who's the founding director of the Play to Prevent Lab, as well as the PI of this grant. So we are one of 10 research projects, as I mentioned, for HEAL. And all research projects had 2 phases. Now for us, the first phase included years 1 and 2. And in years 1 and 2, we developed the video game intervention to prevent the initiation of opioid misuse in adolescents, with plans to deliver the intervention in school-based health centers. Then, in partnership with Shell Games, and Shell Games is a game development company, if you're familiar with Daniel Tiger, they did Daniel Tiger. We built the intervention informed by health behavior change theories and findings from our focus groups and interviews. And then we completed pilot testing with a near final game. And we had 34 adolescents determine our preliminary efficacy, usability, and acceptability of the game in May 2021. So this is the process. This is the stage of how we develop our games at the lab. To inform the content of our intervention, we conducted focus groups and interviews with opioid naive students between the ages of 16 and 19, an individual between the ages of 16 and 25, who was in treatment for opioid use disorder, treatment providers of those who are in treatment for opioid use disorder, prevention specialists, as well as adult affiliates and youth from the School-Based Health Alliance, which is a national organization. And we met with all of these people, participants, I should say. Ooh. Hello? Hold on 1 second. Apologies. Are you guys still there? Hello?
We're here.
Oh,
Yep, we're here.
Yes.
Good. Okay, sorry about that, guys. So we met with all of these people to really understand the perceptions on opioid misuse in older adolescents. Audio recordings of each focus group or interview, they were transcribed and analyzed, and then salient themes were extracted to inform the development of our Play Smart video game. So here are the salient themes that we extracted, right? Then we took this list and iteratively worked with our team as well as the game development team. This was a very intense process to translate it into content and skill development. And this is the content, and this is the skill development that I'll discuss with more detail in the next slide. So 2 impactful approaches in game design are storylines and mini games. Now, storylines ensure that the content is relatable and age appropriate. And then mini games allow the players an opportunity to really practice and build skills through repetition. So based on what we learned from focus groups and interviews, as well as the literature, we designed 6 storylines and 6 mini games that address risk factors as well as protective factors in opioid misuse. Storyline titles are listed here, and topics ranged from a visit to the dentist with a focus on developing health advocacy and an opportunity to learn more about alternatives to opioids, to navigating peer pressure at a party, to a scene with a mental health provider in order to normalize seeking help for outpatient therapy. Now, the mini game titles are also listed here at the bottom, and they ranged from the player engaging in several battle chats when hearing a friend spread misinformation, to comparing future orientation to current self and then identifying the discrepancies, to a player identifying warning signs for emotional distress and then applying coping strategies in the situation. Now, again, I just want to say I'm highlighting this work to show the process that we're currently following to build out the support ed game, because we are in our earlier stages of the support ed game. We literally haven't launched just yet, but I'll get into that with more detail soon. So our next step for the HEAL project is the evaluation stage. Now, we recently transitioned into the second phase of our project, and this is going to be years 3, 4, and 5, where we will conduct a randomized control trial with 532 students in 10 school-based health centers. We plan to evaluate implementation strategies in 15 national implementation sites, and conduct cost analyses. And here's how we launched the current project. For phase 2 of the RCT, the eligibility criteria is the following. Report not having engaged in opioid misuse. So if students ever misused a PERC, Oxy, they would not be eligible to participate in HEAL. In addition, they have to be considered high risk due to either substance misuse in the last 30 days or exhibit symptoms of anxiety and or depression.
I have a question.
Yes.
So if you're saying they have to be opioid use naive, but they have to have some part, the high risk is that you've used, all right, you've got them there. It's basically anything but opioids.
Yes.
That's illicit or illicit. I got it. Okay,
Yep.
thank you, sorry.
No, it's a long list. So I'd rather,
Yeah.
You ask, it's a very long list. So, and the last thing is just, provide assent, parental guardian consent if under the age of 18. Now, again, students who click yes to this question or who report yes on this question, as I mentioned, they will be unable to participate in HEAL. And then they're going to be, when we'll download reports sporadically, they will then be referred to our current project, a completely separate project. So what is our project? Little background information. So suicide is the leading cause of death in adolescents aged 14 to, a second leading cause of death, excuse me, for adolescents aged 14 to 16. Now this number accounts for approximately 240 deaths annually. Adolescents who misuse opioids were on average 1.5 times more likely to experience suicidal thoughts and behaviors as compared to adolescents who did not misuse opioids. Now, what's important to note is that while adolescents who report current prescription opioid misuse may be at highest risk for suicidal thoughts and behaviors, all adolescents who report prescription opioid misuse in their lifetime are at an elevated risk, according to the research. So in thinking about how to address, it's promising to know that students who reported suicidal thoughts and behaviors were significantly more likely to seek services of school-based health centers as compared to their peers. And importantly, students who participated in high-risk behaviors, including substance misuse, were more likely to use the services from school-based health centers. So while tailored school-based prevention approaches that address the intersecting risk and protective factors between suicide and prescription opioid misuse among adolescents are critically needed, little research has been done to identify the intersecting factors to build an effective intervention that targets those who are at greater risk. So we know that school-based suicide prevention approaches exist, and we know that they remain the most cost-effective approach to addressing suicide in adolescents. However, few are high quality. In addition, most approaches target universal prevention, and they don't really provide support to adolescents who are at greater risk. And then to date, most digital prevention interventions that address suicide, they deliver psychological self-help. And yes, that may be helpful or it may be promising, but from the research, most targeted adult populations, and then in the 2 studies that addressed adolescent populations, one had difficulty recruiting participants and the other was delivered really in the form of online modules. And so just translating, taking, a document and translating into technology, a technology-based slide is not really an engaging approach. So a noted limitation for that study was a lack of engagement and completion of the treatment modules, highlighting the need for a more interactive and engaging intervention. And that's why we are doing what we're doing. So as part of my YCCI Scholar Award, I will focus on this aim during year 1. So using methods developed by our multidisciplinary team who have extensive experience in developing video game interventions for adolescents over the last 10 years, we are going to conduct 6 focus groups with 30 participants, and that will include 20 high school aged adolescents and 10 school-based behavioral health providers. We will learn about their experiences related to mental health, suicide, and opioid misuse among their peers or their students. We'll extract themes to inform the content and storylines. And then, as part of Aim 1B, in collaboration with our longstanding partnership with Digital Mill, Ben Sawyers, and then Katie Stinchfield, who's part of the National School-Based Health Alliance, we will develop a theory and evidence-based video game intervention called, as I mentioned, Support Ed, by integrating constructs from the intersectional ecological model, as well as threading some techniques from motivational interviewing to enhance engagement. Gameplay throughout this short prototype will lead to the completion of the evidence-informed practice of safety planning. So as I mentioned, we will apply the intersectional ecological model of, now this is, it's actually for LGBTQ health. So while it was developed for LGBTQ health, it really captures some key theories to consider, and it includes intersectionality. So little background information. In 2011, the Institute of Medicine released the Health of Lesbian, Gay, Bisexual, and Transgender People, Building a Foundation for Better Understanding. In this report, they really explored the health status of LGBTQ communities and identified gaps in LGBTQ health research, and then proposed research priorities for LGBTQ populations. 4 conceptual frameworks guided the studies, and they are listed here. Then, as a result of this report, Mink et al. Proposed a new theoretical model that we will apply, that we're currently contemplating, but leaning heavily towards applying this one specifically of the ones that we looked at. And it is the intersectional ecology model. And it combines elements from the following: social cognitive theory, the Lazarus model of stress and coping, all 4 conceptual frameworks from the Institute of Medicine that we just saw, the report, and then also an asset-based wellness approach to consider as well. So in reviewing the model, it really thoroughly, it explains how the individual, the group, and the environmental factors, but it also illustrates how hypervigilance induced by stigma really pervades the disease process, and it exacerbates the stress cycle. So the question then becomes, how do we help students cope with these social and cultural stressors? And how do we strengthen the person and their community assets? So what's our plan? Well, we will be conducting descriptive qualitative research, as I mentioned, through the focus groups of 30 participants. The study design will be cross-sectional. We will use a semi-structured focus group guide. The guide will have sections which correspond with the theoretical framework. Pilot testing of this guide will occur prior to data collection, and the focus groups will be approximately 60 to 75 minutes long, with an additional 10 to 15 minutes of rapport building prior to the focus group to develop trust and comfort in the focus groups. Field notes will be taken during focus groups to highlight important points and observable behaviors. Transcripts will be audio recorded after obtaining verbal consent, and then transcribed professionally. Debrief summaries will be completed by me and Fran after each focus group separately, and then we'll take them and look over them. Additional notes will be added after reading transcripts and prior to coding. And I plan to use open coding to analyze the data and highlight the themes that emerge. So trustworthiness in qualitative research, as we all know, speaks to the credibility of data analysis. And some researchers compare it to validity in the quantitative field. And I know, I know some are cringing because we don't like to compare qual to quant. But to enhance the rigor of the study, I will, do the following: PeerG Briefing, and I am considering actually making an amendment to my IRB for triangulation. Before I get into that, PeerG Briefing will consist of discussions with Ashley Hageman, who's my qualitative research advisor on my mentoring committee, as well as my mentors, Lynn Feline and Hilary Blomberg. Triangulation, as I mentioned, is a key feature of qualitative research, and I'm hoping to employ source triangulation by corroborating focus groups with different members of the school, or different members who, with exposure to opioid misuse. And so I say that because we are meeting with school personnel. We are planning to meet with students and peers of youth in high school. And then I am considering expanding it and adding youth in college as well, because the target age that we're focusing on is 16 to 19. And so for that reason, 18 and 19-year-olds in their first or second year of college may be added to the amended to the IRB protocol. So, and the purpose of selecting diverse participants is with varying knowledge and experiences, is really to provide a variety of perspectives. And lastly, and I'm really, really excited about this, and I thank Fran so much for just being an incredible support in this work. We will be doing member checking for participant and respondent validation through our Youth Advisory Board. So working alongside this project, I received a small grant from the University of Wisconsin's Department of Pediatrics, and they have a program called Technology and Adolescent Mental Health Program to build a Youth Advisory Board. The mission of our Youth Advisory Board is to promote mental health awareness and normalize seeking help in their schools, as well as provide input on the development of our digital game. So once our focus groups are conducted, youth will review the findings and then provide additional insight. So here is my timeline. We currently got a bit delayed because in addition to IRB approval, I'm required to submit to the NIH's National Center for Advancing Translational Sciences. But what I heard is that it probably will get up and running in December from those who are submitting. And so I'm looking forward to conducting those focus groups in December, probably early January as well. So this is my first year, and the first year, the sole focus is building, the development of our video game intervention over the course of the 2-year projects. And in year 2, we will then have a prototype for our digital game. And the plan is to evaluate with 60 adolescents who have reported opioid misuse. We will look at the usability and acceptability of the intervention and feasibility delivered in schools. We will also look at proximal outcomes as a potential means for behavior change in the support ad versus the control group. And so those are intentions to use the safety plan, coping strategies, opioid misuse in the last 30 days, as well as suicidal thoughts and associated risk factors. So in the end, we plan to deliver a prototype of an evidence-informed prevention intervention to address suicide prevention in adolescents who misuse opioids. And my hope is from this to submit a K award to build out this work with our preliminary efficacy and support schools with their implementation. So thank you so much for attending, and listening and letting me share out. Of course, shout out to my team and my mentors, advisors, collaborators, and partners. This work can never be done alone. So I thank all of them so much. And I thank all of you for being here with me today. If you want to follow more, our work from our lab, here are some social media handles where you can. And now I'd love to answer any of your questions. After this, I do have some specific questions that I'd love your thoughts on, but before I jump into that, I actually would love, I'll stop sharing. I would just love to answer any questions that you have, get your thoughts, and, just hear from all of you.
Well, thank you. In having unshared your screen, Claudia, things have moved around on my screen. So I'm not seeing everybody quite the same way. So if take what Claudia said and just shout out, because I can't really see if you raise your hand. I'm not able to see it that well.
I have a question.
There you go. Thank you.
That was just so fascinating, and I loved having the opportunity to hear about what you're working on. This is amazing.
Thank you.
I feel so naive in that list that you provided for inclusion criteria, all like that paragraph of substances that you're looking at. So I'm just, and I think I know the answer because it's NIH, but I wonder, does it just have to be youth who abuse opioids preventing suicide, or could it just be any substance abuse? And
so youth who misuse other substances are at greater risk of opioid misuse, right? And so what we're trying to do with the HEAL grant, we're trying to prevent ever misusing opioids.
Okay, so they may already be using like a gateway
marijuana
type substance.
Yes.
And then you're trying to prevent them from going to opioids.
Yes.
Oh, but not prevent them from using the current substance that they're using, or not, or maybe not prevent like continued use of that substance.
So that will be, we are looking at those outcomes, like, because for like the HEAL Cooperative, we are asking questions across the board and harmonizing our measures across the board too, across the 10 sites. So we are looking at, and ideally, yes, playing the game, that would be a phenomenal outcome, right? If they reduced or stopped misusing, but that's not our primary outcome. So we are looking at that, but it's just our primary outcome is like, perception of great risk of harm, because we know that is inversely correlated, that increasing their perceptions that opioids, because that's what we found in the focus groups, is that, you talk about opioids and they're all like, oh my God, no, I would never do opioids. And then you pull out a piece of one pager and you're like, okay, so these are opioids. Here is, it's like lean. Here is, which is like a drink with 7-Up and codeine, and then like Jolly Ranchers, which is very like, it's been around for a really long time. And then there's also like Percocets, oxys, and they're like, wait, that's an opioid? So there's this disconnect. Like it was very clear. They knew that heroin was, was a strong, they knew that their perception of great risk of harm was high for heroin. But when it came to oxys, lean, perks, Vicodin, it's almost like they didn't even know that those were opioids.
I'm going to even take you one step further. This is a sad comment on what I see when I go to the medical examiner's office. First of all, I think this is incredible work that you're doing, because I am aghast at, I haven't crunched numbers, but my sense from just going through cases of people who have died of an opioid overdose is that the age is getting younger and younger. So you are really at a place that you need to be. But in reading through the narratives, so many of these people, and that's not just the adolescents, that's just everybody who has died of an opioid overdose, so many of them thought they were taking a Vic or a Perk or heroin even, when actually, when you looked at the tox, it's fentanyl. So the counterfeit pills out there is stunning.
Yeah. And I was actually even hearing like cocaine at the moment. There is like no cocaine out there right now that is not laced with fentanyl.
Yeah, I don't want to comment because I really don't know.
Right. But I'm just,
I know there's concern about that there is now this, maybe Adam would know more about this, but that there is a rise, an increase in stimulant use with opioid use.
Yeah. Well, and to be honest with you, that was, so when I conducted the interview with the 16 to 25-year-old who was in treatment for opioid use disorder, he relayed that alcohol was not allowed in his home, and he relayed that he was having difficulty falling asleep, and it was because he was using uppers, he called them. And he was saying that he was using uppers, and so he couldn't calm down. And then finally he was just so desperate to for anything that someone offered him a paper bag, a brown paper bag, and he was just so desperate to sleep that it was opioids. And he ended up he said it felt like a warm blanket took over him. And so going back to that, kind of the uppers, and then looking for something to bring you down, especially something that would help sleep.
Claudia, I was wondering, could you talk a little bit, I'm just interested in how, what's that process like of turning the focus, moving from the focus groups to storylines? That's really interesting to me.
Yeah, so, oh gosh, it takes months. It starts with storyboards. So because we know that digital interventions, one, are so expensive, it starts with storyboards and starts with mapping out the gestalt of the story that we want to target, right? But then you start breaking down specific goals, right? So what are the goals, and how does that translate to the learning goals? And what are the specific outcomes that we want to target? And what's the process that we're targeting? What's the theory that we're integrating into this process so that they can get there? And so it's almost like each storyline has, a set of objectives and goals, and each storyline has a storyboard that you go down this and this is the answer, and then or you don't, and then you go down this and this is the answer, and then each block has what happens in this, what's the point, what's the goal, what's the key takeaway. It takes months and it's around the clock. It's a whole team effort. It's one of the most you're just immersed in the process, and it's an incredibly iterative process, and so you just keep going through it. And sometimes you just sometimes it works and it goes, and then sometimes you have to, okay, let's go back to the drawing board. That doesn't flow, that feels choppy, doesn't work. So it really is an incredibly collaborative effort, and that translation is it's fascinating, but it definitely it's an around the clock thing that's very iterative. And it can't be done by one person. So and that's when I know a lot of people are transitioning into the digital world, which is fantastic. But it's really about building a team that can work together on translating this work and have those lenses and have different skill set and different ways of thinking about things to build it out in that way.
Were you able to do the focus groups in person, or was it during COVID?
Yeah, so I conducted the majority of the focus groups in person, because when COVID hit, it was the tail end of our focus groups. And then it was almost, because we transitioned quickly into, I think it was a month later, we started meeting with our game developers to start building out the game and the analysis and everything. And so it was data analysis time and translation. And then we started working with the game developers. So, but I have to say, we transitioned, we did conduct a couple of focus groups virtually. And, we had a process that we did. We met with, someone who had already, Frank, who already had previous experience conducting virtual focus groups. So we met with him, we talked about how to do it, what do you think is what works. We then started with expectations, we did encourage people to have their, again, this is, I understand people don't want to always have their videos on, but for something like this, it does that is the purpose of the focus group. And so we say that early on, that the expectation is that cameras will be on, and that they will be actively participating, because it is, and we give them a gift card. And then, I would conduct it, and then we would have someone on who would provide technical assistance, who would be able to, if someone's thing went off, if they would having technical issues or anything, that person would provide extra support and say, hey, FYI, is there anything I can do to support you? I just saw that you went off screen, just to kind of nudge as we're continuing to flow. And that person's also taking field notes and observing the behaviors, the nods. We encourage, people to say, if someone says something, please put in the chat, same, agreed, so that we can document that. So we do, we just had to, I feel like the last 2 years has been an enormous pivot, but we pivoted, and we learned things that we wanted to do, and then things that we're well. So for example, there are schools that will allow me to go in, but I may actually just conduct virtual focus groups, because that, that I can then get students from different schools as opposed to just one school. So that can open it up to allow for different experiences of their peers from a variety of schools in Connecticut. So, again, I always say it's we pivot, and then we learn, and then we improve the next iteration. We do our best. I think we all did that, right?
Yeah. You never know what you're going to find when you get out there.
You never.
I have a question that kind of follows on what Yuka and Meredith have been talking about. Basically, given that you are dealing with very sensitive issues here, opioid use, misuse of any substance, suicide, why, what was your rationale for opting? These are sensitive issues. What was your justification for conducting focus groups as opposed to individual interviews?
Yeah, that's a great question, and I appreciate it. So, in my experience of conducting focus groups, people have shared more when they talk about peers, especially adolescents, because what we've learned is that adolescents worry that when they share something, that then they're going to go to the counselor, and then it's going to turn into this issue, and then it's going to escalate, and they're going to have to and they even said that to us on several occasions. They were like, anytime you get the counselor involved, it always complicates things, and it causes more problems than good, because it becomes about following protocols, right? Because they have to also make sure, the goal is to ensure that you are safe. But what I've learned is that they sometimes feel like they have to scale back on what they say because they're worried they're going to get in trouble, which is again, this is another drum that I'm banging in the background of we need to rethink how we approach school-based support services, and how we create supportive systems in the schools. And that and so I say that because what we learned, or what I've learned in this experience, is that when you talk about it from a perspective of your peers, someone you may know, share a story about someone you may know, they then have a tendency to actually share more. And we end up getting more more robust and stronger content, because I'm not talking about myself. The first focus group we talked about, we were talking about some real, but again, it really, they knew more about opioids than this group, right? This was supposed to be my opioid naive group, and we did have opioid naive groups, but this group knew more about opioid. They knew about sizes, how things were sold. They knew all this information, but again, they weren't talking about it from the perspective of well, this is my experience. They were talking about it from the experience of someone I know. And so we just found that they were a little bit more forthcoming in that.
It's interesting, and thank you for, I'm glad you had a rationale, but then that kind of begs the question of, how trustworthy is this? If you're hearing something that the person heard indirectly, maybe it wasn't accurate, so I don't know, that's one of the things that I think about. The other thing I wanted to ask you about was, you made a comment about suicide prevention interventions were of poor quality, and gave us a wonderful example of it. But what did you do, if anything, to kind of determine that your review of existing interventions that were out there targeting this group with this subject were good or bad? Did you have some kind of methodology?
I wouldn't say it was really more a cursory review from previous systematic reviews. It wasn't but previous systematic reviews that looked at suicide prevention. And I also say that as someone who worked inside schools, and probably 10, 15 years ago, you didn't talk about suicide in schools at all, because and if someone talked about suicide in schools, what ended up happening was the student would be removed from the school, would have to go under psych evaluation, and would not be able to return to school unless you had a signed document from the doctor saying that the student may return back to school, right? And we're learning that, again, going back to what we talked about kids feeling like when they share something, they're punished, right? So we're going back to that model of I think this focus on mental health is very new inside schools. This especially related to COVID, and that there's been conversations, but it's been very sporadic in how schools address suicide prevention. That the focus has very much targeting scratching the surface and only focusing on universal interventions, when thinking about, and that's why there's been an explosion, which is great, of school-based health centers, because that provides schools with support to be able to kind of target some at-risk students who are at greater risk, because one, you have a little bit more manpower, and two, school-based health centers are like a separate entity, and their healthcare services on site inside the schools. So they're unique in what they're able to do. And part of their work is providing and addressing substance misuse.
I wonder how much schools are, it makes me kind of think about when eating disorders kind of came on the radar, and that there could be a concern of, if we talk about this, it's going to be, a contagion. Absolutely. That's going to run through, is that what has kind of delayed any kind of
Absolutely.
education?
That is, and the research says otherwise. So the research says talking about it prevents, and actually asking about it does not cause suicide. And so that's something that even for, as I prepare for the pilot RCT, because I will be asking questions about suicide, that is something that I have to cite in my IRB protocol to highlight, here, these are the research articles that, show that asking about suicide does not cause suicide. So,
I mean, it's variation on this, on a similar theme of, if you distribute condoms in schools, right, everybody's going to be engaging in sex. If you hand out, clean syringes, everybody's going to be shooting up, and that the data just don't.
Exactly. Yeah.
Yet another example.
Exactly. And so, and I think we are having a reckoning inside schools of a lot of times, and as someone who has worked inside schools, if you don't talk about it, it doesn't exist. And we know that's not true. We know that with bullying. We know that with, victimization inside schools. We know that does not exist. But what happens, and so I think we are having a reckoning inside schools. Now, that being said, schools are strapped. So to put that onus on them alone, it's not feasible. So the bigger picture and the bigger question is, how do we put, and again, my internship was with Turnaround for Children. It's on site, but it's separate services similar to school-based health centers that provide wraparound services. We need separate entities on site at schools to provide this type of support. And that's my soapbox.
Well, I mean, it's kind of like, it's to me, sounds like a variation sort of on an EAP that you would find in, most employment environments, that I'm sure the teachers have an EAP that they can go to. My question, I guess, would be, what is because the EAP is always, and they really let you know that, the employee assistance program, is that it's purely confidential. Nothing will go back to your employer. I don't know if that level of confidentiality is afforded. Yeah.
No.
Yeah.
Yeah. Unfortunately, there is some with school-based health centers. They have a little bit more, like, I also think there's variation state depending on the state, but school-based health centers are, because it's a health care, it's primary care essentially. Families can go there and get their health care. So there's some flexibility around, those details. But Lauretta, is it okay if I actually transition to these discussion points that I just want to, get
Meredith has unmuted herself. So
okay.
I did, but I think it's an easy question. I was just wondering, I guess I just talking about this made me wonder, where do people get the games? Like, are they only can they only play the games like at the school-based health centers, or can they download them from like a Apple store?
So a quick response is you can get the games. The games that are completed are currently available for free. And you can get them by going to our website, playtoprevent.org, and then just requesting. There's a place to request the games from our team. Dr. Lynn Feline, though, recently launched Playable, which is her goal is to commercialize the games so that she can get them out, so the goal is to then get them out more easily and more readily, building a back end so our team doesn't have to send user IDs and passwords, but it actually is like a back end so that it's a little bit more automated, et cetera, et cetera. So there is it's a whole process before that launch, and the goal is to get them evaluated first before they launch. But you can certainly, in the stages that they're at right now, you can play the majority of them. And I actually do have, one of the slides after I go through the discussion questions, I can share some usernames and IDs if anyone on the call is interested in playing PlaySmart, specifically the one that's from Heal.
But it's I guess I'm wondering, so who would typically reach out to Play to Prevent? Is it schools, like the counselor, or
typically schools, any, you look at the games and you say, oh, I'm interested in this topic, because they're different topics as well. Okay. So, one is on smoking and vaping, one is on increasing access, to school-based health centers for HIV and STI testing. So they really there's a variety of topics for the games. Yeah. All right, so I'm going to share my screen again. And I just had a couple of questions. I would love your thoughts. Just thinking about, all right, so. All right, so do you have any recommendations to explore that would improve or enhance our methods? Are there suggestions on other frameworks that we should review that focus on intersectionality? And then any thoughts about rapid analysis techniques? Is it worth exploring and considering in our data analysis plan? And I can actually, because I can't see you guys, so.
No, I'm watching. Everybody's muted right now.
Oh, okay.
But I was going to say, you may want to leave those up so that people can
I was going to put it in the chat so I could see you guys.
Oh, okay. All right, good.
So I can, yeah.
I am struggling with to rapid analyze or not to rapid analyze myself. And I think that it seems like a lot of what can drive that decision. And I'd love to hear from other people. Too bad Katie Clark isn't on today.
I know.
She would, I'm sure she has a lot. And I think I sent out to the group, there is a VA listserv for qual methods. And there was something on, although CMIPS last here at Yale had a presentation on rapid analysis. It I think has to do with, what's your timeline, who all is involved in, how big is your group in the analysis? Is it going to delay you to have one person in charge and disseminate it out? What is gained by having everybody have access at all times to, the data, the spreadsheets that essentially will be your analysis. I do have to get the templates from the VA person. But at any rate, I don't have an answer, but I think it's something that needs to be clearly reasoned in your mind of why you choose to do what.
Right.
Meredith?
Yeah, I was going to say, I agree. It's actually, this is a conversation I've been having a lot with people lately, and I completely agree with the idea. The most interesting one I had lately was someone pointed out to me that they're like, you can have multiple research questions or multiple research aims from your data collection. And they're like, rapid might be a good fit for some, and more traditional might be a good fit for others. And so the point was like, just think about it as part of your bigger strategy, right? If you're compressed for time, if there's something that's a really good fit for rapid, to not think of everything as being end all be all, which was sort of helpful, right? And then the other thing that somebody has said to me recently is, which I really appreciated, was this, that what makes something rapid in that, we I think that rapid analysis is really tightly associated with implementation science and using like a real tight framework analysis. But this person I'm speaking to was saying, you could code in rapid. Maybe what you are doing is you are having a more rapid approach in your other methods. So they were like, maybe you're coming in with some of the code book already done, and then you're just adding inductive codes. Or maybe you're doing an intense lit review that sort of reduces the learning curve on the analysis time period, right? So they were talking about, thinking about it was interesting to hear somebody talk about breaking the tie that rapid always means implementation science, and it always means coding to a framework, and that's 100% what it means. It was interesting.
Yeah,
actually, I will say, following on that, Meredith, I asked that question of the VA researcher who presented on not radar, but on a different rapid analysis, and actually it was interesting. Part of her reasons for going the rapid route was it was a lot easier. And if any of you work in VA systems, you'll know what I'm talking about. It was a lot easier to have data in Excel and Word than to have it in a software program that is not, either approved at your site or approved by the VA, that it was just a lot more accessible. So that's one thing to consider. And it's not just time. I mean, even though rapid says time, it's time, it's resources. If you don't have the money to be able to professionally transcribe, and PS, I got to tell you, Teams is really fabulous. Teams and Zoom at this point, doing transcripts automatically. The day of the professional transcription service, I think the sun is setting on it because it's there.
Oh, thank you so much, because the person who I typically transcribe with is not available. I just put on her radar. I was like, hey, just FYI, you'll be getting a bunch. I just want to put it on your radar, put us in the queue. And she was like, I'm booked up, I'm sorry. So Zoom does do transcriptions?
Oh God, yes.
Is your account a School of Medicine account?
Yes.
Oh, that's true.
Then you have to get switched. So I just went through this because I had the same thing not for transcription, but for closed captioning. I have someone I work with who needs the closed captioning, and I had to have it. Yale School of Medicine doesn't even allow that. So I had to have my account set differently.
That's a really good point, Mary.
It's not impossible. But
do you have to contact IT, and did you have to pay?
I had to contact ITS, and what I did was I just made a big case about, nobody in here is paying attention, that I also have funding at School of Public Health. And in this case, the person I work with is at School of Public Health. And I was like, this is something that we need for them. And so they just switched my Zoom to the School of Public Health standard.
Do you see what's going on right now?
So when they switched my account, they just switched it to public health settings.
So public health allows it, but medicine doesn't. Wow.
Yeah. We are HIPAA exempt over at YSPH, but that being said, I don't know, because certainly the VA is not HIPAA exempt. It comes to much more of, does this involve patient data, PHI, or is this more of a quality improvement where, it's not talking about my experience or my diseases, it's talking to experts, and that's a way around as well for people.
Oh, great.
I'm sorry, one further clarification. In order to do live captioning and the transcript afterwards, you have to be able to record to cloud. At Yale Med cannot record to cloud. They can only record to desktop, and that's the main reason why. But if you switch over, you'll be fine.
Right. So this is Helen. Actually, the reason for that is that if you are using a HIPAA environment, you cannot save to the cloud. So that's why the medical school won't allow you to do it.
Hi, Helen.
Hi. Just peeking in to see what you're up to.
I love it. I love it. So happy to see you, or so happy to hear you.
Yeah. So, but there's back to the rapid issue. It can be justified based on multiple reasons. Time, money. What the question is, who you're interviewing, things like that. So
yeah, and you could just also put, which is fantastic. So I will look into both of these options. This is huge, because again, through my YCCI Scholar Award, I have very little funds to do, to really for the research over the course of 2 years. So
actually, let me give you a hot news flash from Yuka. She said that she used AI transcription service, not too bad, 25 cents per minute. Yeah. Hers is www.t as in Thomas, em as in Mary, I.com. I don't know if you're seeing this right now. And I know that we use Trent. I mean, we on one of our projects. And turn around, and actually we were able to do them in Spanish too.
Oh, that's fantastic.
So they have Trent, TRINT, will do them very quickly, and do them in multiple languages. They don't translate, but they transcribe in different languages.
Yeah, this is huge, all of this. So I appreciate everybody's suggestions. And again, and it's also helpful just to hear the thoughts of rapid analysis techniques, because that's where I am at too. It's not a quick yes, no, it's like, well, and so, Yuka said it best. I think she said, in order to do rapid analysis techniques though, you do have to make sure, did you say this, Yuka, that like, your understanding of how to do the old school qualitative approach is like strong. That you can't just and you could please feel free to jump in if I'm butchering like what you said. But like you can't, yeah.
That was my takeaway from when Allison Hamilton spoke. She's at the VA also, was you know, the PI of whoever is leading the rapid analysis. She strongly recommends that they are have a lot of experience with traditional qual methods, because she was saying, I wouldn't recommend, you know, if you're not familiar with qual methods, I wouldn't recommend trying to do like a abbreviated version of it, because you have to know sort of where you're rapidly doing and where you're not, and you know, to not compromise on the rigor as much as possible. So she was actually saying, as Lauretta mentioned, it's a great way to be able to bring in folks who traditionally wouldn't do qual methods. It's a great way to sort of expand your team, because you may not rely on, you know, the softwares and things like that. But she highly recommended that the person leading the team was someone who was really strong in qual methods.
And I'm going to give the flip side. I know I've talked about this in other QRDG sessions. The flip side of that is you also need somebody who is well grounded in rapid analysis, because on our project, we wanted to do a rapid analysis, and we were two of us were very well grounded in, you know, traditional qualitative analysis methods. And we could not make the transition. We just were kind of kept on going back. So you need somebody who would be the cheerleader, who speaks from experience on the rapid analysis as well. Otherwise, you're not going to do it. We didn't do it. We abandoned it.
Oh,
yeah. And that's
I have a question in response to your first question about recommendations to explore that would methods.
Please.
So, I have very little research experience with youths, but a long time ago, I had tried to start a project with a younger group, probably like elementary to middle school. And at the time, I was looking at sort of different techniques, especially for younger children who may not have, you know, full verbal like adults, you know, showing pictures during interviews or focus groups, having them draw things and then talk about the drawing, and, you know, because they're just verbally. So I know your group is an older group, but it seems like what you're describing earlier around, tell me about someone else's story, or to me, that seems like a focus group interviewing strategy to have them talk about things kind of like, you know, draw me a picture and tell me about this picture, like it's a little bit removed from the outside. So I wonder if there's any more literature now around sort of those type of techniques that you would use with youths who have much more verbal skills is not what you know what I'm trying to say, like compared to an adult, but they're not fully, you know, an adult yet. So like, is there something out there that speaks to like best practice with youth, getting them to talk about
definitely.
That's not like picture drawing.
Totally. You know, it's interesting because what I have found in working with, you know, just adolescents is, you know, their responses are curt, right? They're very terse at times. So I really encouraging them to expand and using that language, which is, we do it throughout qualitative research. Like, wait, so walk me through that. Tell me a time where that happened. Like, I actually have to have them give me a specific example, because they will provide one phrase or one word in their responses. And again, I just think that's the elaboration, you know, that encouraging that elaboration is the most critical part of working with teenagers, because you want to make sure, but then once you get them going, they're like, they just go. But you just have to, and the other piece too that I say is that recognizing, you know, I have more like once someone gets me going, I can chat, but also realizing that there are variations of like, you know, comfort around speaking. And so if I feel like someone is speaking a little bit more, because there are sometimes some adolescents who speak who then, once you get them going, they're like, boom, 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 boom. And then kind of like, okay, so, you know, really deliberately checking in on those who haven't shared much, or, you know, I start off a little, because, and this is just my style in general, it's always, even as a teacher, I start off really structured in the focus group at first. So I give them their like, okay, person one, person, you know, ID number, each has an ID. Before they speak, they say their ID. Like we get, it's really, really structured, because inevitably by the end, it does kind of evolve into its own like freestyle in some way. And so, but that structure allows us to create sort of that, again, working with teens, I think setting that expectation that everybody is going to, you know, talk, that the process of that, you know, it's not just one word answers, that we want to hear, you know, oh, so, you know, ID one said XYZ, you know, has anyone had any stories that are similar or actually different from that story, to encourage different points of view? And again, it's just giving them the permission to feel that like, that they can disagree, that they can, you know, and I think the elaboration piece is probably one of the, like the skills around that. And to the point that you made too, you know, we did know going into the focus groups and realizing that they did not know, not all of them knew what opioids were. We then brought a one pager and had that one pager with pictures of different type names and types, you know, of, you know, purple juice, or, you know, Slizzerp, you know, different things that we heard, you know. We referenced, like, we also, you know, tried to get it, we referenced like music that reference opioid misuse, right? And, you know, talked about that. Like, it's just like, it's almost like once you get that connect, it flows, but it's just sort of, you know, encouraging elaboration and making the connection to the content.
I think that what you're really describing right now applies to focus groups and individual interviews. The whole querying, I mean, one of my least favorite responses for an interviewer is, oh, I understand, or gotcha. You know, that a lot of times, no, you may not understand, and that maybe you do need to query more. So, you know, I always say, listen for the provocative. And the other thing is that you are setting up a culture, regardless, again, if it's a focus group where there certainly is going to be much more attention paid to group dynamics, because you've got group dynamics going on in a focus group that you may not have in an individual interview, but you're setting up the culture of respect.
Absolutely.
Of, we're not gonna, we don't want a one-word answer. We're not gonna accept that. You know, that's fine. Those are all good interviewing skills.
And to the point that you just made too, like my guides are, I get made fun of because my guides are so long. They're so long. But the reason they're long is because, and again, I know how to navigate the guide, but because I end up asking sometimes the same question, but in different ways, depending on now, if they respond to the first way, and I feel like they understood that question, and I feel like I got a robust response, okay, we don't have to ask it the second or third way. But if I feel like it fell flat, and different groups respond differently to different questions, right? So sometimes I'll then say, okay, and then I'll ask the question a little bit later and in a different way and see how we go. And then, you know, and if it flops, maybe I'll ask it again at the end. Like, I just sort of, like I said, but if not, then I'll cross off those questions if I feel like we did get to that. So that's another thing too, that I always do, of just like I said, my guides, everyone's always like, oh my gosh, you know, these are so detailed. And I'm like, it's providing the like template for me, but I'm actually driving it, and I decide like which ones I'm going to use.
Well, this has been wonderful. I'd love to hear, you know, that people have been discussing, which is great. And this is a fabulous project. We're going to hopefully hear back from Claudia later on when she's further on in this project later on this year. I want to thank you. I want to be mindful of the time, however, and I'm sure that if you have questions for her, she can be reached at Claudia. Is it Claudia-Santi?
Yeah, I'll put it in. I'll
word,
put it in
or?
right now. So and thank you all so much. One, I did not know how today was going to go. I thought it was going to be me, Lauretta, and Fran. And so just because it's the Friday before Thanksgiving. So thank you all so much for being here, for engaging in these discussions. That's why I love qualitative research discussion groups, because our meetings, because I always feel like we're all in the same boat. So thank you all so much for being here.
Well,
my email's
and
right
I want to
there.
thank everybody. Yeah, I want to thank people for contributing, because I feel since COVID, the group dynamic that we had when we were all in the same room is not quite the same when we're all doing this via Zoom. But hopefully one of these days we will be back in the same room, with the exception of the people who are always welcome from elsewhere in the country. We love you guys. But yeah. Thank you so much for a really great session.
Great
Thank
job, Claudia. Thanks, everyone.
All right.
Have a great weekend.
Have a great